Legal and Ethical Considerations, Chapter 6. These are the objectives for this lecture. We're going to work on differentiating ethical and bioethical terms and work on the 5 ethical principles. Describe legal process of the admission process and discharges. Describe patient rights, etc., etc. So, terms to know. You need to know these. We will be practicing and applying these to our mental behavioral health arena. Okay, so ethics. The study and philosophy and beliefs about what we consider right or wrong. We talked about how this applies to our culture, okay? And when we were just in our cultural chapter. Right and wrong. Bioethics is the relationship to what we in our health field, okay? So when we talk about an ethical dilemma, that's that conflict between 2 or more courses of actions. So it could be favorable or unfavorable consequences. So when we're talking about a paranoid schizophrenic patient, and do we choose to have that patient use a old school antipsychotic or a new school antipsychotic? Do we want to just treat the positive symptoms, or do we want to treat the positive and negative symptoms? Which drug group are we going to use of those antipsychotics? Do we want to have just more of focus on movement disorders, weight gain, and sedation as the side effects? Or do we want some movement disorders and metabolic disorders as our side effects? What are the things that do we want to deal with? What does the patient want to deal with? Also, when you're looking at page 93, we are looking at box 6.1, Code of Ethics for Nurses. And when you're looking through this, the nurse, all professional relationship practices with compassion, respect for inherited dignity, worth and uniqueness of each individual, every individual, unrestricted by considerations of social or economic status, personal attributes, or nature of health problems. The nurse's primary commitment is to the patient, whether an individual, family, group, or community. The nurse promotes, advocates for, and strives to protect the rights and health and safety of the patient. The nurse has the authority, the accountability, the responsibility for nurse practice, making decisions and take actions consistent with the obligation to promote health and provide optimal care. The nurse owes the same duties to self as to others, including the responsibility to promote health, safety, preserve wholeness of character and integrity, and maintain competence and continue personal and professional growth. And it goes on. Read those. Be familiar with those. How do you implement those components? So the 5 principles of bioethics. Benefits, to duty to promote good. So you're doing it because it's the right thing to do. I pick up that sheet because it's the right thing to do. I don't want somebody to fall down and get hurt. I don't want to have an infection in the hospital. I do it because it's just right to do. I don't do it because I know I'm going to get in trouble, or even the fact that it's a bad outcome that's potential. I do it because it's just right. Autonomy, respecting the rights of others to make their own decisions. Now, it doesn't mean I don't educate and re-educate. It just means I let that person make their decision. Justice, distribute equal resources and care. Okay, so this is where we come up with a lot of our rules and our practices. So, for example, regardless of whether you have insurance or you came in and you're voluntary or involuntary to my facility, I am going to make sure that you are going to get your history and physical within 12 hours, that you are seen and have your psychiatric evaluation within 24 hours. Regardless of if you have money or don't have money, it makes no difference. Equal. Okay, justice. But then here's another way of looking at justice. I have two patients who are physically fighting in an altercation with each other. And and we go and we need to do least restrictive measures. So we're hollering and saying, "Hey, stop hitting, stop fighting." And one of those patients stops hitting, and they go and redirect and walk down to their rooms, and I send my staff members down there with them. And one patient's on a one-to-one, but this other patient, instead of continues to hit that patient, they start hitting and swinging and fighting with the staff members, and that patient ends up at 4-point restraints. And so the team's meeting, and the nurse says, "Well, this isn't fair. Both patients should be in 4-point restraints right now, and you've got one on one-to-one, and this one's on 4-point restraints. They should have the same consequence." This nurse is looking through the eyes of justice. And not all the time is justice the appropriate response to have, the same consequence. Sometimes you have to do things as individualized treatment. So you have to look at when justice is and isn't appropriate to distribute resources and equal care. Then there is fidelity, maintaining loyalty and commitment, do no wrong to the patient. Your fidelity should always be to your patient. And then there is veracity, one's duty to always communicate truthfully. One prime example is when you're doing your med education, you need to tell the truth about your side effects. That is a prime example of when that needs to happen. Or what about when you're clocking in and out for work or your lunch break, let alone any other circumstances of an event? Little things of telling the truth demonstrate when you are going to have a big incident and whether you're going to be telling the truth. Rights. 1960s, we deinstitutionalized our patients. Back in the day, if you had Down syndrome, you had intellectual disability, you had autism, you were locked up and the key thrown away, let alone if you had schizophrenia, bipolar, depression. People were put into hospital settings and never given out. They used to call them insane asylums. Things have changed and come a long way. We looked at rights. You used to not be able to get a driver's license. You used to not be able to vote. You have civil rights. You're able to do community-based treatments now. We have things like the ACT team where people go to the community and make sure you take your medications, that you're able to go and continue on with your care and your treatments and seek the care that you need these days. Where Okay, so what we're going to do here is we're going to look at our patients coming in. We're going to look voluntary and involuntary because this is going to happen quite often. When patients within the first 24 hours of arrival, you're going to hear a conversation that says, "I need to leave. I need to get out of here now." Remember, your patient had a crisis out in the community. And now they're going to be having usually a second crisis that's going to arise. It may be over the fact that they don't have someone to care for their kids or their animals, or the mere fact that there's other people here are crazy and they're not, or they're panicking because they're not able to do their normal coping skills, or that their job is in jeopardy. But there's usually a second crisis that arrives when they are at the hospital. So there's a few things you're going to do. You're going to first start off with figuring out what status this patient's in. Are they a voluntary or an involuntary status? So that you're doing that so you can pull the right paperwork. You're going to get a writ of habeas corpus if they're involuntary, or you're going to get a request to be released paper if they're a voluntary patient. In a writ for habeas corpus paper, all that is to make a statement to the court to ask them to expedite the court hearing. So court hearings can happen anywhere from 7 to 14 days from time of admission arrival for a patient. Okay, so it's just telling them to expedite it, move it, make it happen. And usually then we see it within anywhere from 5 to 10 days, that court hearing. So, and the least restrictive alternative doctrine, all that is that I can get treatment through outpatient, PHP, IOP, but it's a lesser restrictive environment that I can get this care and treatment from. Okay. So then the next step is you're going to sit down with your patient and you're going to say, what's going on? What's happening? What changed that things were so bad that they're not so bad anymore? You wanted to kill yourself yesterday, but you don't anymore. What has changed? What's taking place? What's so urgent? What's happening? Okay, so you're trying to find out so you can help this person problem solve their crisis that's happening, and see if you can get the resources that they're needing to help manage that, so we can focus in on truly what's going on and brought them in. And then that voluntary patient, what you are going to do is write down and have them sign the date and time they're making the request to be discharged. And then you're going to call and write down the date and time you have informed that psychiatrist that they want to be released. The psychiatrist, typically in the state of Florida, they have to see the patient within 24 hours to have released them. Sometimes they will do it just right over the telephone. Sometimes they will not. They want to come in and see. And say they just saw them a couple hours ago, and they'll say, I'll go ahead and release them. And sometimes they will not do that. It's not safe. I can't do that. So they'll we're concerned. Sometimes there's an issue with the job, and all we need to do is actually get a letter up to the job to notify their HR department that they're there, because maybe their boss has called and their boss is being inappropriate and doing some things or saying some things that are not within the law. And all we need to do is help engage their HR department without their boss knowing that they're in a psychiatric hospital or some other components. So that their job's not on the line. So there's so many things that we can do to assist this person with their care. So discharge procedures. Remember, discharge begins at the time of admission, and there's some things that we always do. Create a safety discharge plan. So who's their support person? What was their weapon of choice? What are the who are we going to set them up with their appointment? We want to have them be seen within 7 days of discharge. Where are they going to get their meds filled at? And we're going to need to have a supply. How much of a supply are they going to be eligible to have, and it be safe for them? Sometimes it's not going to be safe for them to have their meds, and so we're going to have to document why it's not safe for them to have those meds. So there's a multitude of things. Then we talk in your book about different types of discharges. An unconditional release is that is where the court releases, because there was a court hearing and the judge says, nope, they cannot stay. They're to be released. Make sure you do not release until the court papers arrive to your facility. And sometimes they do not arrive the same day that court hearing occurred. That is not your facility's issue. You have to wait till the court papers arrive. Then there's a conditional release. That is where the doctor's doing the paperwork. All that means is the patient is eligible, if they deteriorate, to come back into a higher level of care. And then there's a release against medical advice. That is not a discharge order. That is just a release against medical advice. All the documentation is going to be in progress notes. Okay. Understand that under a conditional release and a release against medical advice, the facility as well as the providers can all be sued. Because you are the experts and you are the ones that know best for the condition of the patient. And just because the family and the patient is demanding to be released does not mean that they are safe to be released. So we need to effectively communicate with our patients. So patients have rights. Let's get into them and discuss some seclusion restraint elements. They have a right to treatment. They have a right to be free from excessive medications. So you guys, Texas-sized dose, adding a little bit extra pinch so that they sleep a little extra longer is not appropriate. They have a right to privacy and dignity. I have seen where people have failed to knock and trigger PTSD, especially on people who have had rape and trauma issues. And people didn't knock on bathroom doors before you checked on them. And yes, we do need to visually see our patients, even if they are in the bathroom. So you knock, you have them cover up, but you have to go in, you need to see them. You can't come back 5, 10, 15 minutes later, because again, it only takes 3 to 6 minutes for permanent damage or death to occur. So coming back is not the option for us when we are checking for somebody trying to commit suicide. So they need to cover up, but we need to get in and see and make sure they're okay and they're not up to something. All right, so with all of this, they have rights to attorney, clergy, healthcare providers. They can say no to ECT, all these different things to do. Look at table 6.1 on page 95 and 6.2 are on page 96 regarding some of the decisions about medicating somebody against their will, or emergency treatment meds to be forced on a person. They have a right, people have a right, even when they are involuntary, to say no to their medications. They have a right to be informed of risks and benefits to their medications. When a patient is mentally ill and their functioning is deteriorating, they have serious mental illness, the benefits of treatment outweigh the harm of the treatment. They lack the capacity to make reasonable decisions, and less restrictive services aren't working and are not appropriate. Those are the times when we have to petition the court to medicate the patient against their will. We don't have an option not to do that. This is when we have to go in, because the fact you just can't keep a person in a hospital forever and not do anything. That's not benefiting anybody. That's just holding them prisoner, and they're not getting any better. So we have to do something to help medicate them. And then when you're administering chemical restraints to a person over and over and over again, that's not doing any good either, because every time again you're putting restraints on a person, and you're increasing the likelihood of death by 10% each time you're touching them. So JS is a 27-year-old male, is court committed by his parents to your unit with a diagnosis of paranoid schizophrenia. He lashes out at staff when you attempt to give him his medication. He states, "You're trying to poison me." JS continues to argue with staff. He is not aggressive, but he refuses all treatment. Legal and client rights are suspended when the client is hospitalized involuntary. Is that true or is that false? You should be answering that as false. So he can still say no to his medications. The family of JS asked you, can you force him to take his medicines? How do you respond? Your response should be saying, no, we cannot. We can, however, administer emergency meds to him if he is in serious imminent danger to himself or others. Without a court hearing, we cannot do anything else. And then go over the criteria that he meets regarding having this court hearing, which he does meet those components. Okay. So, rights of an involuntary commitment of advance directives. So, one of the things I want to talk about is, we talk about advance directives for medical, but we're also advance directives for psychiatry. Okay? What happens if you get dementia or Alzheimer's or you become psychotic? Have you ever thought about that? Did you ever think about getting something set up? So if this happens to me, this is what I want you guys to do. Who is that person that's going to speak for you? What do you want to have done if you get psychotic? If you develop dementia, what do you want? What are your plans? What do you want to have happen? Where do you want to go? What kind of care you want to have? Actually, if you do get really angry, upset, what are the things that do calm you down? Having those things in place can make your care so much easier instead of it being trial by error. What about seclusion and restraint? When we as nurses have a patient coming in, we actually have to educate people about seclusion and restraint and find out who their person is of contact that to notify them if this does happen. We also have to do medical and trauma assessment very quickly on them so that we know, because we know that seclusion and restraint can be very traumatic for patients. We know that injuries can happen. You also need to know that seclusion is less dangerous than restraints. And remember, chemical restraint is a restraint. So keep that in mind. You're not only having to necessarily hold a person during a chemical restraint, you're actually introducing a chemical into the body that's going to be affecting organs and brains and heart, etc. So it's not just a short duration, but a long duration after you've put them through physical stress. And now you're putting a chemical on top of it. So keep all of that in mind when you're doing this with your patients. Okay, so these are all last resorts when we're using them. Also, there are time frames within a seclusion restraint event. So first off, because of psychiatry, you cannot pre-plan a seclusion and restraint event. So typically, it's going to be in an emergency situation. You're not going to necessarily be able to obtain orders before you need to do it. So a registered nurse only is able to implement in an emergency a seclusion or restraint event. Not chemical. Chemical, you're going to actually have to call and get the order before you can administer, because there are no PRN chemical orders. Okay, so with this being said, if a child is under the age of 9, so 8 and under, they can be in seclusion restraint for up to 1 hour. If you are 9 to 17, you can be in for 2 hours. And if you are 18 and older, you can be in for 4 hours. Now, what happens if you have an emancipated 16-year-old? Federal law says 2 hours. They're 16. It does not matter if they are emancipated. Okay, always remember that. Go by the age. Now, with that being said, there are some other things that are there. So, to protect the patient from any abuse, that being misuse of seclusion and restraint within the hour of the event, even if the person's out of the seclusion or the restraint or the injection of the chemical restraint, there has to be a qualified person who assesses the patient and the event to ensure that it was not an abuse of the authority and use of this event, and to ensure the safety of the patient has not been injured. Okay, and that needs to be done within the hour of the initiation of that event. So all of that being said and done with our seclusion and restraints, before we even implement it, you need to have ensured that you have done all the least restrictive measures beforehand. Okay, that means you have verbally intervened and tried to get the patient to cooperate to stop it from occurring. You have reduced all stimulation. You have actively listened. You have provided diversion. You have offered PRNs. And you have done this over and over and over to try to reduce the use of this. So this is where we try to use quiet rooms that are like meditation rooms. Think of like dim lights and mood setting kind of situation where the patient can just go there all on their own to quiet themselves down, or use timeouts just to do, you know, let and direct the person, let's go take a timeout and see if you could calm yourself down. But remember, a seclusion, you can tell somebody to take a timeout, but if you tell them and then don't let them come out of timeout when they want to come out of timeout, and you block the exit of leaving a room, you have just created seclusion. Seclusion does not have to be behind a locked door. So keep that in mind, okay? And then, of course, and you can have an actual locked door. And to create seclusion is another way of doing that. And you would want to do seclusion before you would have to use an actual physical restraint. Now, also keep in mind, a physical restraint doesn't need to, it could be soft leathers. That would be, when we use soft leathers or a soft cloth or leathers, those are what we call in our world mechanical restraints. When we talk physical restraints, that's when you're using your own personal hands to hold somebody down, okay? So I want to give an example also of a physical restraint and how long a physical restraint is and when we call it a physical restraint. So if you're holding a 5-year-old attention deficit, hyperactive deficit disorder child and they're in your program and you're walking from building A to building B and that child happens to dart off and run off to chase a ball and you let go of them while you're holding hands because you're just holding hands to hold hands, and they run off, that's not a problem. But you're holding hands just to hold hands and that child goes to run off and you clamp your hand down to keep them from running off, you've just committed physical restraint. Even if you just do it for 5 seconds, you have committed physical restraint and you need to document that. So once you place that person in restraints, you're going to be documenting on this person every 15 minutes for physical needs, hydration, toileting, food. You're going to be doing vital signs. If somebody's going to be assigned to them for one-to-one, you're going to need to be within ear, visual, and physical reach of this person. And auditory, so that you ensure their safety during this entire time. You're going to release them as soon as possible. Okay. All right. And the next thing is you need to provide as much confidentiality as much as possible during this period of time, because this person needs to be able to return back to the milieu without everybody knowing their business. You're going to do a staff debriefing. You're going to be doing a patient debriefing. You're going to need to add a care plan regarding violence, and the seclusion restraint is going to need to get added in as an intervention that occurred as a one-time incident during their stay under that potential or that actual violent situation. Oh, and let me go back to this a second. So part of that informed consent that psychiatrist or the physician is going to go over is the nature and concern of their problem, the nature and purpose of the treatment, the risk and benefits of the treatment, and alternative treatment options. So now we're going to go into confidentiality, okay, and your duty to break confidentiality. So we have HIPAA, okay. So we need to make sure when we are doing releases that we are ensuring for like labs, we cannot send urine drug screens nor HIV status results without the actual written release stating on labs that those things can be sent. Otherwise, we do not send that work to the next care provider. If we are sending a patient to the emergency room from one facility to the next facility, back and forth, in the emergency room back to us, we do not have to battle to have the release of records sent because it's an emergency situation and it's continuum of care. However, in an ideal situation, we want that release signed. But when it's an emergency, at this point in time, we're going to call, get that information sent over so that we can continue care with that patient. Okay? Otherwise, we want releases signed. We are not going to be releasing information after death to their family members. So if somebody wants to know, I always wondered if my family member was abused as a child, that information, we are not going to be sharing that. It's confidential. In psych, we do use PIN numbers to acknowledge whether a patient is or isn't in the hospital. You will hear a lot of comments. I can't acknowledge if this person is or isn't here. It's up to the patient to share their PIN number to their family member. It is not the facility's responsibility to do that. And that's only to say that they're here or not here. It's not for us to release any information. The patient would actually have to sign a consent to release for us to share information. Okay. Along with those notes we have some exceptions to report. Okay, so on page 98 under exceptions to the rules, here's the first one: duty to warn. This has to do, and it started in 1974, and it actually had to do with the University of California and the Tarasov versus the Regents of University of California. This had to do with a professor who had a student at the university very fixated, and the professor referred the student over to student health, and the counselor started seeing the student. Counselor became very concerned about the student being very fixated and on this professor, and to the point that the counselor was concerned the student was going to kill this professor. And so the counselor did not have the authority under their license to involuntarily admit this patient into a hospital. So they told, so the counselor called the police and had the police come to her office. And when the police met with the student, this police officer decided that the student did not pose as a threat and did not follow through with taking the student over to the hospital to be involuntarily admitted. And approximately 2 to 3 months following this incident, the student actually saw the professor on campus in the parking lot, and the professor did not know that they were in danger, and the student stabbed the professor to death. And hence came the law. The family pursued this because the police were aware that their threats were made. The counselor knew the threats were there and it was really legitimate. But this professor was not aware and was not able to protect themselves. So we now have a law in place that when we are told by a patient ever that there is a threat that they're going to kill somebody, we are now obligated to inform that third party that there have been threats made against them. Okay? So when we have a patient threatening to kill the governor, the mayor, their spouse, or whomever, we now need to warn them. Okay? Now, you're going to find that your policies at your work don't necessarily completely follow what our laws say or when your NCLEX goes to test. Your policies at your hospital will say you're supposed to tell your psychiatrist and tell the therapist, and your therapist and your treatment team will get together, and the psychiatrist or the therapist will go and call the family members, and usually this will take 24 hours or longer to get done. Here's where your problem's going to lie, because this has happened in real life, folks. Because of all this delay in calling, your patient escapes from your facility. They get out, and so before anybody can get this person they are threatening to kill notified, they have met up with this person and have killed them. It's too late. You didn't make the call. They're dead. Your facility can't protect you. But I was following policy. But you have to follow the law. It's your license. You're in trouble. So your policy needs to get updated. You still need to do your job. So when you do it all right, and so this is why you got a couple hours to move and get these things done, not 24 hours. You do not go home at the end of your shift and not have this done. So if you want to have the therapist call and do it together, but get it done pretty quick. Don't sit and wait, because somebody can get out of your building. When there is a will, there is a way. Okay? But make sure that you take and do your due diligence and make that call, make it happen. The next piece that you want to make sure that you do is when you are doing all these steps right, because you don't get to do this a lot. These incidences don't happen as often as you think it happens. So you have to educate people, because you don't have it happen very often. So when these events do occur and you see it all happening, then educate. You're going to do grand rounds, and you may be the presenter with your therapist or with the doctor, and you're going to say, this is what all presented, so this is how we handled this. This is how we did our notification. This is how we told. You can't tell this person all and break confidentiality about all the events. What you're going to do is talk about how you notified them. These are the steps. This is how we did it, and this is our time frame of how we got all the notification happened. At River Point, at Wekiva, we end up with the FBI out there. We have to do those notifications that these threats have happened, because we have to protect those public figures. And we don't know how legit or not legit. And there have been times when students have had the opportunity to actually go and walk the patient up front to the FBI, because those threats were legit. And when they went and checked the person's home, it was all set up with all the stuff for stalking and all those things. It's not just psychiatric. Sometimes it is also criminal, and so those things have to be addressed and looked at. And so it's a good learning experience to have those things, to learn about those things. All right, the next piece is on child and elder abuse reporting. This is on page 99. It's going to be in the second and third paragraph under statutes for reporting child and elder abuse. And where you see the 3 bullets, those are where the exceptions are. So if you're in a regular psychiatric facility, you're going to just call up the 1-800-ABUSE hotline, and you're going to say, hey, this is Teresa Thody. I'm a registered nurse over here at River Point, and I am calling to report that Sally Smith has informed me that she has been taking her cigarette butts and burning her child on her back and torso. She's 3 years old. She's right now staying at her grandmother. I have the mother here at this facility. I'm reporting these things so you guys can begin your investigation. She's at our facility right now. I do not know when she is going to be released at this time. Yep. Yes. And discontinue the call. The address at our facility is blah, 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 blah. Okay? And the call. I'm not breaking any confidentiality laws at this time, because abuse takes precedence over confidentiality. Okay? Now, I'm working now at Lakeview, freestanding substance abuse treatment facility. And Sally's patient over there. I can't do that. Now, most substance abuse treatment facilities have call blocking, so you cannot identify where where they're calling from. Okay, so according to your bullets, the only time I can release any kind of information on abuse or anything is if it's court ordered, if the report can be made without identifying the abuser as a patient in an alcohol or drug treatment program, and if the report can be made anonymously. Now, the state of Florida does not like you to make a call anonymously, and they may choose not to take the call from you, but you have to try. That is the only thing that you can do. And so what is going on here and why this is so confusing is federal law and state laws conflict. And the state of Florida says you have to report, but federal laws say if it's in a substance abuse facility, you cannot. And this is where we conflict. You are licensed by the state, but federal can come and take your license away. And this is where it's very frustrating. So this is what you do. You make sure your call is completely blocked when you call into that 1-800-ABUSE hotline. And you call in and say, I'd like to report an abuse. The person's name is Sally Smith. This is their address. This is what they did. Good day. And then in a personal notebook, you put the date and the time you made that call. You put initials and you put what the abuse was, and you put no more, no less. You don't put addresses, you don't put nothing. You just put that and you leave it, so that if there is any point in time the state comes at you, you have it documented. These calls are recorded. They can find it, and you did do your due diligence. If the feds come at you, it doesn't anywhere acknowledge that you did anything or broke any confidentiality. So you've got your evidence. One way or the other, you're covered. All right. Defining laws, torts, neglect, malpractice. So a tort. Civil wrong. You can get money. Intentional torts, okay? These are when you violate a person's rights, okay? And you did it intentionally. Assault. Assault is using your words. We see this happen, especially when somebody is having countertransference in psych world. This is where you swear at somebody, you threaten them. I'm going to move you, I'm going to put you in seclusion restraints if you don't stop that right now. You can't say that. Okay. You're being unsafe. In order for you to be safe, you may end up needing to be restrained. If you could just stop hitting, we will not have to put hands on you. Versus saying it, I'm going to put you in seclusion or restraint. That's threatening. Two different ways of how to reword these things. Battery. Okay. You don't need to be injecting somebody with drugs that's saying, I don't want them. Don't inject them. That is battery, putting hands on. False imprisonment, holding somebody against their will. Invasion of privacy. Not knocking before entering in a room. Bathroom. Again, that PTSD, triggering the whole event that could end up turning into a holding that patient down and restraining them because you didn't knock and they thought they were going to be raped again. Defamation of character. Remember, slander is words. Liability is written word. I should say slander is verbal words. Liability is the written word. Putting things out on Facebook. Any of that kind of stuff. Putting judgment versus actual fact down. Neglect, malpractice. This is getting into medication errors. Not starting an IV with the wrong equipment, doing things that you just may not know how to do or not being competent enough to do. 5 elements to prove neglect: duty, breach of duty, cause and fact, proximal cause, and damages. Read over those components and look at Common liability issues in table 6.3. That 6.3 is on 101, and the unintentional duty components is on page 100. Okay, so now we're moving into the Nurse Practice Acts. So, what says your role as a nurse, an RN, an LPN, your scope of practice, an ARNP, an RNC, any of those components? That is in your state board of nursing. Then you have your professional boards or organizations, your institutional policies and procedures, and your customs of standards of care. These are all the things that we have that we practice. These are customs of standards are what we usually do this, okay? These are, let's see, this is how we usually do it. These aren't necessarily standards, okay? Institution or in the policies, sometimes they don't always meet standards. They get behind. So you have to point those out to your facilities, especially when new equipment comes in. Did the policies get updated to reflect the new equipment? Okay. Always know you need to be functioning and elevate to your American Nurses Association, your Psychiatric Nurses Association. Be within the scope of practices of your professional organizations and your board of nursing. That's where you need to be functioning and practicing with. So, which of the following identifies the titles that a registered nurse will use and what they are allowed to do? Your answer should be A, your state boards of nursing. So, negligence, responsibility, or impairment, duty to intervene and duty to report. You have to report incompetency, impairment, or criminal activities. Who do you report? The nurse. Will vary from state to state. So here's the deal. You need to be able to do and complete your job duties and responsibilities. This is essential for you to be able to do. One of the things I would recommend doing in page 102 is to remember to read your vignette. It gives you a nice little scenario of understanding what we're talking about with a scenario. But you need to make sure that you are, let's see, how do I want to word this? Okay, so let's start with this because this is where it gets, how do we want to do this? We have several scenarios that can happen. Some states require when you need to report and when you don't need to report, and who you report to. Sometimes you report to a peer, the impaired nurses group. Some require you to report to your facility, your HR department, your supervisor. Some require you to report to the state board of nursing directly. But here's the bottom line. When you have somebody who is impaired and it is a safety issue and it is impacting direct patient care, and you look at it through their ability to perform their job duties and safety, you need to immediately intervene and address that with the supervisor and intervene to protect your patients. That is bottom line. It needs to be done right then and there. If it is not interfering with patient safety, then this is where you need to look at your state laws, and this is where you can then engage the impaired professional practice group and have them reach out and touch base with that patient, that nurse. And so what are we talking about and what are we looking at? So I'm going to give you an example of something that I had to actually deal with. And my director of nursing actually had me deal with this versus him. And you'll understand the reason behind why he had me do this. He called me down and I was going to be the 3 to 11 supervisor. And he said, I need you to go talk with one of the nurses down on the stabilization unit at one of the hospitals I was working at, and I was the supervisor. And he said, she came in, she's just not dressed professionally, and this is where we could just wear regular clothes to work. And he goes, I just need her to go home, change her clothes, and come on back in. And I said, why can't you do it? And he goes, and he goes, because it's just not appropriate for me to have this conversation. I was like, okay, you're gonna have a better thing for me to go down and do this. You're the boss, I'm not. And and I'm giving him a little hard time about it. And it's like, listen, her breasts are hanging out, her bra's hanging out, and her pubic hair is hanging out. I cannot be having this conversation with her. I need a female to do it. Okay, Teresa, just go do it for me. I'm like, okay, I get you now. All right, so I'm going down there and I'm meeting with her, and she has pressured speech. Okay, it's rapid. And when I'm meeting and having this conversation with her, and sure enough, we have a purple bra. We have some breast cleavage. Her sleeves, our dress code is you need to have cap sleeves. Okay, you need to wear bra and panties. Your bra and panties cannot be hanging out. And you definitely cannot be having pubic hair hanging out, okay? She had stirrup pants on that were beige, and you were to wear kind of muted makeup, so we're supposed to have a calming effect. She had bright blue eyeshadow, which was not normal for that era of the 80s, okay? Or 90s. I don't even remember what year it was anymore. And bright red lipstick, and everything was supposed to be more of a calm component. And the vest she had, literally, there were no sleeves, and her bra straps weren't even covered because the vest was so close. And on top of that, the vest was a snap vest. So if you grabbed it and it was so tight that if somebody grabbed it, it was just unsnapped. So she was in the med room and she was working on going through the meds, taking a look and see what patients had for 5 o'clock meds. And I pulled her in the back, and I'm just going to name this nurse Bernadette. And I said, Bernadette, I need to speak with you about your dress today. You're out of policy with your wardrobe. It's not professional, and it's very provocative. Can't even say the word. It's very seductive and bright and not fitting with our policy and procedure. And she looks at me and is very rapid in our conversation. She said, what are you talking about? I look very professional. And I said, Bernadette, your bra's showing, and you've got a purple bra on. I can see a lot of breast tissue. And whether you realize this or not, you do not have underpants on, and I see your pubic hair sticking out from your pants. And she just looks at me and so you're kidding me. And I said, no, look in the mirror. But on top of that, you don't dress like this normally, and you've got very bright blue eyeshadow on and really red lipstick, and the lipstick is very outside of your lip line. And you don't dress like this. And as she's talking with me, and I just went ahead and acknowledged, your speech is very rapid and very pressured. What's going on? Are you okay? And she just continued to talk and talk and talk and talk. And she started jumping around, and she's like, I'm much worse than I thought I was. I'm much worse than I thought I was. And I was like, what's much worse? What's going on? And she just finally said to me, I'm bipolar, and I knew I wasn't doing well, but I didn't think I was this bad. And I was like, Bernadette, what? and she, just I knew my mania was starting up, but I thought I had it in check enough. I'm not okay. I live 45 minutes away. I can't. It's going to take me a long time to go home and change. And I just finally said, Bernadette, you're telling me your mania is out of control right now. It's a just go. And she's like, I can't come back. And I was like, no, you can't. Go home. So before this even got worse, this is where she recognized she was impaired. Okay. I didn't have to finish recognizing that the rest of the way. And it didn't get to that level. But these are those early warning signs before it became a safety issue. And actually, it really was a safety issue. I'll fill you that in just a second. That wardrobe component was enough. Okay. It was just enough that it was out of, and this is how you have to address it as an employer, of you need to be functioning within your scope of practice and following your job duties and responsibilities. We hadn't gotten to a safety component completely yet, but to address these things as they're going along. She did go home. When I went in to look at what had gone on with her meds, she had the meds all over the place in there, and patients were definitely going to be getting the wrong medications. I still couldn't figure out how, to this day, what she was exactly doing with those meds, but medications were mixed into wrong patients' drawers. We did not have a Pyxis system back in those days, so she was pulling drugs from all sorts of different directions and putting them in other patients' drawers. It was just an interesting world that had occurred this day. So needless to say, we prevented a lot of med transcription errors, but that is a potential safety component, and that's how you have to kind of start addressing them. So when somebody has problems like being able to do a care plan properly, that's not impairment, irresponsibilities. That is somebody needing to learn how to write a care plan and do a better job at documenting a care plan, or a skill. Okay, so there's a difference between neglect, irresponsibility, impairment. Okay, what about that nurse that chooses not to rotate that patient every 2 hours and they develop wounds? Neglect. Those are those kind of things you've got to start looking at and reporting. So and that's when you have to look at criminal activity at that point in time. Or what about the nurse that's diverting drugs? That's got to be reported to your boss right away. Those are those things that have to be done. Okay. Be always weary of the nurse who does drug narcotic count out with you and then offers to go back in to give a patient a drug after they've done drug count. Be very wary of those. Okay. All right, so now we're into documentation. Remember that when you're documenting, you're using it to evaluate later. Read the changes from beginning to end. Get the status report. Check the beginning to how a patient was at the start to the change at the end. That helps us. We use the medical record to look at quality of our treatment, our care. We use it as evidence and legal to look at the damages of patient's suffering. I've been in many court hearings, especially because of the assessments that I've had to do with children and adolescents at the time of arrival on their physical assessment for abuse cases, and all their markings and documentation of comments from parents to child, and used a lot of quotations about what has been said. So just be aware that those things are very much used. I've had to do things where family sessions, I've been called as supervisors and had to document conversations over the phone with psychiatrists that I've had to have discussions with because we've moved clients from one unit to another unit for higher levels of care or lower levels of care after different sessions have occurred, because the patients deteriorated. After a session, they were threatening to kill their whole entire family members, and the psychiatrist would not come in and meet with this client. The client ended up killing themselves the next day. The psychiatrist swears they came in that evening, but my last note said that, you know, the psychiatrist refused to come in, and then they spent 4 hours drilling me, literally 4 hours, you guys, non-stop, saying that telling me that the psychiatrist came in, and all I could say is that my note says it didn't. I have no recall that he did. It'd been 5 years. I don't know what you guys want me to tell you. I don't have that person did, but I also had to work on another unit. I can't tell you any more than that. You know, so, you know, if the unit staff didn't tell, there's no orders, the psychiatrist didn't put a note in, I can't tell you any more than that. You know, so it's having all that information there. Psychiatry and mental health facilities have been the last to start getting in the electronic documentation. There's still a lot of places that still don't have all of it in place yet, but it's coming along. It's nice to be able to have it at a touch of your finger, to be able to look at information very quickly than to have to thumb through everything. It's nice to have it at a touch of a finger. But it's coming along slowly but surely. Okay. All right. So then we have forensic nursing. I wanted to talk about this here. We use and apply our nursing principles in the court of law to help assist in decision making. We use nursing education in court on the science of nursing, and we also provide many opinions on the appropriate nursing standards to assist with forensic nursing. And this is all part of what we do. Many things that we do in the lands of forensic nursing. You can see more in Chapter 33. Also, we can identify healthcare workers at legal protections from violence in the healthcare setting. So this is our next thing, was we know in the land of psychiatry and mental health that we are going to see a lot of more violence. So with this, you need to understand that employers are not typically responsible for employee injuries from violent patients. However, things have been changing, and we do have and federal laws have been changing regarding having workforce violence in the workforce trainings, as well as in psychiatric mental health. Healthcare workers now are required to have trainings such as Handle with Care, NAPI, CPI, all sorts of different trainings to help manage aggressive patients. We also, nurses participate in help setting policies on maintaining safer environments and recognizing danger in our environments. We also work on documentation of potential violence, and we need to make sure we're communicating to our colleagues who is violent, and making sure that handoff communication is happening. We should not be walking into our clinical areas until we have gotten a report and know who is and isn't dangerous, or who is been agitated, not agitated, and assessing for agitation. So a nurse was a case manager for a client with a serious mental illness for 6 years. The client died by suicide 1 week ago. Today, the client's spouse asks, "I always wondered if my spouse was a victim of sexual abuse in childhood. What can you tell me about that? Can the nurse disclose information to a surviving spouse?" Everybody should have gotten this. The answer is no.